question worded here is acute pain management service. Okay. So what is the definition and causes of acute pain will be the introductory statement that you make. Acute pain usually comes on suddenly and is caused by something specific. That is the description of acute pain. And it is sharp in quality. Acute pain usually does not last longer than 6 months. That is the maximum time it should disappear. It resolves when there is no longer an underlying cause for the pain. For example, if a surgical wound, when it heals nicely within about say 2 weeks to 3 weeks, it should not cause further pain for the patient. And what are the causes of acute pain? They include surgery, trauma, dental work, burns or cuts, labor and childbirth. And after acute pain goes away, one can go on with life as usual. This is the beauty of acute pain. They will not be hovering over that. That is why so many people come for surgery. Because once that initial period, post-op period pain is over, then they become pain-free and they are able to carry on with their normal life. So what are the consequences of acute pain? There are many short-term and long-term consequences of inadequately treated acute pain. These include hyperglycemia, insulin resistance, increase in risk of infection, decreased patient comfort and satisfaction, development of chronic pain, and the autonomic nervous system is also activated by pain and is responsible for the associated symptoms seen with pain such as nausea, sweating, alteration of heart rate and blood pressure. So these are all the unwanted effects or the consequences of perceiving an acute pain which is not properly blocked or treated. So why pain needs to be treated? Properly implemented acute pain services reduce the length of hospital stay, lowers readmission rate, and helps in speedy recovery. These are the three major advantages of organizing an acute pain service. One, it reduces the patient's hospital stay. It does not warrant a readmission for the patient to come back again and helps in speedy recovery for them to go back to their normal life. So it also improves quality of life, enhances productivity, and decreases the cost for the patient and the healthcare. So if you are able to provide good pain relief, nowadays we mainly concentrate on daycare surgeries. So if we are able to provide good pain relief, we can send the patient back home within 24 hours or at the most 48 hours. So this reduces the cost for both the patient as well as for the healthcare system. And the goals of acute pain service is to provide effective and safe pain management for patients by one, assessing and treating and managing the pain, preventing and managing side effects and complications related to pain medication, monitoring patient outcomes, data collection and quality improvement. It is not enough that if you just organize a pain service, you must collect the data. For example, if you treat acute pain in 50 laparotomy patients, you must see how many of them got fully relieved, how many of them had some residual pain, how many of them had long-term pain. All this data has to be collected, analyzed periodically, and you should try to improve the quality so that you achieve 100% success in all the patients. So that should also is a part of acute pain service. Consulting and supporting nursing and medical staff should be there, and providing staff and patient education programs, closely collaborating with surgical or medical teams involved in patients' overall acute care. So these are the 7 goals that you have to keep in mind to provide an effective and safe pain management service for the patient. And who should form the team? Usually, the team should consist of an attending anesthesiologist, anesthesiology residents, nurse practitioners, and registered nurses. These are the 4 categories who will be usually involved in this. And what are the guidelines for acute pain management services in the perioperative setting? Practice guidelines are systematically developed recommendations that assist the practitioner in making decisions about healthcare. These recommendations may be adopted, modified, or rejected according to clinical needs and constraints and are not intended to replace the local institutional policies. Now, institutional policies and procedures for providing perioperative pain management. What are they? Institutional policies and procedures include education and training for healthcare providers. So, first of all, the doctors, nurses, anesthesiologists, the residents, everyone should be educated about the importance of treating the pain and how to manage all these things. So, the care provider should have a good knowledge about that, and patients should be monitored with regard to the outcome, how best they have been relieved of the pain, how they are ambulant earlier, how they are able to take oral, how soon they get discharged. All that should be monitored, and documentation of their monitoring activity is very, very important, and monitoring of outcomes and at an institutional level. That is what earlier I said about data and quality improvement, and 24 hours availability of anesthesiologists for providing perioperative pain, especially in cases of labor and cesarean pain and all those conditions. Use of a dedicated acute pain service. These should be the institutional policies. Now, coming to the preoperative evaluation of a patient who requires acute pain service, proactive individualized planning is very, very important in anticipatory strategy for postoperative analgesia that integrates pain management into the perioperative care of these patients. So, patient factors to consider for formulating a plan are: what is the type of surgery, expected severity of postoperative pain, underlying medical conditions, presence of respiratory or cardiac diseases or allergy, and the risk benefit ratio. You must always weigh it. Lumbar or a thoracic epidural is not the panacea for every case. So, a patient with a cardiac disease, if you put a lumbar or a thoracic epidural, the hemodynamic stability may be compromised. So, you must always take the risk benefit ratio of the available techniques and patient's preference and previous experience with pain. So, these are all the patient factors. Number one, type of surgery. Number two, expected severity of pain. Number three, underlying medical condition. Number four, the risk benefit ratio. Number five, patient's preference or his previous experience. So, all these things should be taken into consideration. Now, what are the recommendations for preoperative evaluation of the patient? A direct pain history, a directed pain history, directed physical examination, and the pain control plan should be included in the anesthetic preoperative evaluation itself. So, apart from your pre-anesthetic evaluation for the fitness for surgery, your anesthetic pain services should also have inclusion of all these points with regard to his postoperative pain relief. And preoperative preparation. So this is the first stage is evaluation. After that, you have to prepare the patient. How do you prepare the patient? Preoperative patient preparation includes adjustment and continuation of medications whose sudden cessation may provoke a withdrawal syndrome, especially patients who are alcoholic, who have been taking alcohol quite for some time. Nowadays, the recommendation is you do allow them to have a small quantity of alcohol. You don't completely withdraw them from that, so to avoid the withdrawal syndrome. And treatment to reduce pre-existing pain and anxiety. Pre-medication before surgery as part of multimodal analgesia pain management program, and patient and family education, including behavioral plan to go behavioral pain control techniques. So these are all the preoperative patient preparation. The fourth is preoperative techniques for pain management. What are the things that you can do preoperatively? One is multimodal medication management, patient controlled analgesia, the perioperative method, peripheral nerve blocks, paravertebral block, patient controlled analgesia, ketamine infusion, lidocaine therapy. So these are all the perioperative techniques. So just a mention of these things is enough instead of going in for detailed description, because the question is worded here is acute pain management services. Now coming to multimodal technique of pain management, multimodal techniques for pain management include the administration of two or more drugs that act by different mechanisms for providing analgesia. So that explanation alone is given. You don't have to mention what are all the drugs you use for that. These drugs are administered via the same route or by different routes. So that is the quality or the nature of multimodal technique. So this is the pain pathway with which, if you remember that, you can remember how to tackle acute pain. So starting from the trauma side, you can use local analgesic or anti-inflammatory drugs. Once the pain is carried to the posterior root, you can manage it by regional analgesic by blocking the peripheral nerve, or you can use gabapentinoids, or you can do gating agents like surface application of topical ice as heat, spinal analgesia, opioid, or alpha 2 agonist at the dorsal root ganglion level. Then the pain is carried to the spinothalamic tract to the upper ascending hair centers. So there it can be modulated by using SNRIs or tremanol, and you can use opioids, alpha 2 agonists, NMDA agonists, and acetaminophen. So these are all the various. This, if you are able to just draw a line diagram of all these things, that will complete. Instead of writing too many sentences, you can just mention this as a very quick reference of how to manage the pain at the various levels. And patient subpopulations. Some patients, which he mentioned as the last, they carry more risk of inadequate pain and require additional analgesic. These pain groups are pediatric patients, geriatric, critically ill or cognitively impaired patients, and other patients who may have difficulty communicating also. So these are the population risk patients. Genetics and gender modify the pain experience and response to analgesic therapies. So patient race, ethnicity, culture, gender, and socioeconomic status influence access to treatment there, as well as pain assessment by healthcare providers. So these are the points. If you just write this, I think that will be enough for mentioning about the pain pain management services instead of writing in detail about the various drugs or various techniques that you want to write. So on the contrary, if the question is pain management, acute pain management, then you can go from the World Health Ladder of pain management, which is given usually for chronic pain. You can start from simple analgesic to NSAIDs, opioids, alpha 2 agonists, all that details you can give, and also about the various nerve conduction blocks or the central neuraxial block, all that can be mentioned for acute pain management. But if the word services is included in the question, I think this way of presentation will be a much appreciated one than going in for a detailed wasting your time, because you have to, as I repeatedly say, you have to finish your answers within 20 minutes for a long question, if it is asked as a long question also. Okay.
Thank you, sir. Thank you. Sir, one more thing can I add, sir?
Please, go ahead.
The emergency room on-arrival blocks, zero delay blocks, pain relief, acute pain services also now being initiated in many of the centers, sir.
Yeah.
So it comes under the purview of pain management services team.
Acute pain, yes. Okay.
Yes, sir.
So that will be preemptive